Namaste Vidya, Amisha Khushro Vidya. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Associate Professor and HOD, Department of Practice of Medicine and Faculty of Homeopathic Science at JYOTI VIDYAPEETH Women's University, Jaipur. In this series of lectures, we have been discussing about various diseases related to the endocrine system. In the last lecture, we have discussed about diabetes mellitus. In this lecture, we will be discussing about one of its important complications of diabetes mellitus, that is diabetic ketoacidosis. Diabetic ketoacidosis is basically a complication that is due to the long-standing diabetes mellitus and uncontrolled diabetes mellitus. So not only long-standing but uncontrolled diabetes mellitus leads to the development of diabetic ketoacidosis. So what is diabetic ketoacidosis? What are the various clinical features of diabetic ketoacidosis? How to investigate a case of diabetic ketoacidosis and the management of the same we are going to discuss in this lecture. So let us start with diabetic ketoacidosis. This is the pancreatic gland or the pancreas, which has both exocrine and endocrine functions. In the endocrine functions, beta cells of pancreas are secreting insulin. Insulin is responsible for the maintenance of the normal blood glucose level in the body. And in absence or in deficient secretion or in non-proper functioning of the insulin, it produces diabetes mellitus. Right. So today we are going to start with diabetic ketoacidosis. What is diabetic ketoacidosis and what are the various clinical features? So diabetic ketoacidosis, in short, it can be written as DKA. Diabetic ketoacidosis, this is resulting from the insulin deficiency with a relative or absolute increase in glucagon and may be caused by, it is caused either by inadequate insulin administration. As I have just told you that diabetic ketoacidosis is basically a complication of the long-standing uncontrolled diabetes mellitus. So it is resulting when there is when there is insulin deficiency and with a relative or absolute increase in glucagon. So what due to deficiency of insulin, the glucose cannot be converted into glycogen, and due to increased glucagon, the stored glycogen from the liver will be converted into glucose. So there will be increased hyperglycemia, and this is caused by inadequate insulin administration. Or this can be due to infection, different type of infection that like pneumonia, urinary tract infection, gastroenteritis, sepsis, etc. Infarctions like cerebral, coronary, mesenteric, or peripheral infarction. Surgery. After surgery, there is increased level of the blood sugar level, and trauma, drugs like cocaine, and pregnancy. So diabetic ketoacidosis is resulting from various number of factors, like if there is inadequate administration of the glucose level, or the person is suffering from any kind of infection, or there is infarction, that is reduced blood supply or absence of blood supply to brain, to the coronary artery, to the mesentery, intestine, and the peripheral structures, or there after the surgery, the blood sugar level is rising, or after the trauma, or if a person is using drugs like cocaine and pregnancy. Diabetic ketoacidosis, basically this is the initial symptom complex. This is not a simple single symptom, but it is a symptom complex that leads to the diagnosis of type 1 diabetes mellitus. This leads to the diagnosis of type 1 diabetes mellitus. And but more frequently, it occurs in the individuals with established diabetes. Those individuals who have their established diabetes, those who are already suffering from diabetes mellitus, diabetic ketoacidosis is seen in all those individuals. Diabetic ketoacidosis from relative or absolute insulin deficiency. So either there is relative insulin deficiency, that is, a person is taking less insulin than required, or absolute insulin deficiency, or the combination of the two, with counter-regulatory hormone excess, like those hormones that are responsible for the increase in the glucose level in the body, like glucagon, catecholamines, cortisol, and growth hormones. So if there is deficiency of insulin, or there is increase in such hormones that increases the level of glucose in the body. Both insulin deficiency and glucagon excess in particular are necessary to develop diabetic ketoacidosis. So both things, like there is reduction or reduced level of insulin and increased level of glucagon, are responsible for development of diabetic ketoacidosis. The decreased ratio of insulin to glucagon promotes gluconeogenesis, as I have just told that when there is reduced insulin, so the glucose cannot be converted into glycogen. And if there is excessive glucagon, then more and more of the stored glucose, glycogen will be converted into glucose. So this leads to gluconeogenesis, glycogenolysis, like destruction of the glycogen to glucose, and ketone body formation in the liver, as well as increased in the substrate delivery from fat and muscle to the liver. The decreased level of glucagon and catecholamines in the phase of low insulin level promotes glycogenolysis. The ketosis results from the marked increase in fatty acids released from the adipocytes, with resulting shift towards ketone body synthesis in the liver. So there is excessive production of ketone bodies due to the increased level of glucose, and metabolism of glucose produces excessive ketone bodies. Ketosis, why this ketosis is occurring? Because of the increase in the free fatty acids from the adipocytes, from the fat cells, with resulting shift towards ketone body synthesis in the liver. Normally, these free fatty acids are converted into triglycerides and very low density lipoproteins, like VLDL in the liver. However, in case of diabetic ketoacidosis, there is hyperglucagonemia, that is increased level of glucagon in the blood that alters the hepatic metabolism and favors ketone body formation from the fatty acids from adipocytes. Now, what are the clinical features? Clinical features of diabetic ketoacidosis. Whenever a patient of diabetic ketoacidosis is coming to us, how can we recognize that this particular patient is suffering from diabetes ketoacidosis? So the initial symptoms of diabetic ketoacidosis includes anorexia, means there is no desire to eat, nausea, vomiting, polyuria, and thirst. So the initial symptoms of diabetic ketoacidosis includes anorexia, nausea, vomiting, and thirst. There is abdominal pain. The patient is suffering from abdominal pain and altered mental functions. So there is abdominal pain and altered mental functions with frank coma or non-diabetic, non-ketotic hyperosmolar coma, that is known as NHC, may ensure. The classical signs of diabetic ketoacidosis includes kusmal breathing, kusmal respiration, this is an important sign, and acetone odor in the patient's breath. Volume depletion can lead to dry mucous membrane tachycardia and hypotension. So the signs of diabetic ketoacidosis includes kusmal breathing and acetone odor in the patient breath. There is volume depletion that can lead to dry mucous membrane tachycardia and hypotension. The fever and abdominal tenderness may also be present in the patients. The patient may also present with fever and abdominal tenderness. So there is the symptoms include anorexia, nausea, vomiting, the polyuria, and thirst. There is abdominal pain with altered mental function, frank coma that is non-ketotic hyperosmolar coma. The classical signs of diabetic ketoacidosis includes kusmal breathing and acetone odor in the patient breath. Volume depletion can cause dry mucous membrane, tachycardia, and hypotension. The fever and abdominal tenderness may also be present. The other clinical features of diabetic ketoacidosis includes nausea and vomiting. So there is prominence of nausea and vomiting in the patient. The abdominal pain may be severe and can resemble acute pancreatitis. The patient presents with severe pain abdomen, and that can resemble acute pancreatitis or ruptured viscus. Like ruptured viscus means destruction of any organ. Hyperglycemia leads to glycosuria. So in case of hyperglycemia, this can cause glycosuria, that is presence of glucose in the urine, volume depletion, and tachycardia. Hypotension occurs because of the volume depletion in combination with peripheral vasodilatation. So the hypotension in a patient is occurring because of the volume depletion. I have just told you that there is polyuria, and also there is peripheral vasodilatation that causes blood to pool in the peripheries. Kusmal respiration, that is a typical or peculiar feature of the diabetic ketoacidosis, and a fruity odor on patient's breath. That is secondary to metabolic acidosis and increased acetone in the body are classical signs of this disorder. There is lethargy and central nervous system depression. So the patient remains tired, that is lethargy, and there is central nervous system depression that may evolve into coma with severe decay. So the patient becomes tired, and there is central nervous system depression that can evolve into coma with diabetic ketoacidosis. The cerebral edema, an extremely serious condition of DKA, is almost seen in children. Now, what are the precipitating factors? What are the factors that precipitate the development of diabetic ketoacidosis? So as we have discussed, inadequate insulin administration. If a person is not taking proper insulin, then this can lead to development of diabetic ketoacidosis. Infections, different type of infections like pneumonia, UTI, gastroenteritis, and sepsis, infarction, cerebral, coronary, mesenteric, and peripheral, drugs like cocaine, and pregnancy. These we have discussed already in this presentation. Now, what are the physical findings that we are going to see in a patient with diabetic ketoacidosis? In a patient with diabetic ketoacidosis, the physical findings include tachycardia, that is, increased heart rate, more than 100 beats per minute. Dehydration or hypotension. We have just discussed why dehydration and hypotension takes place because of the peripheral vasodilatation and polyuria. The patient develops tachypnea, that is small breathing, and respiratory distress. So the patient, because of the increased acidosis, there is small breathing and respiratory distress. There is tenderness in the abdomen, and we have discussed that there is severe abdominal pain as if acute pancreatitis or ruptured viscus may resemble acute pancreatitis. The patient becomes lethargy, and there is cerebral edema, and that can lead to the coma in the individual. Now, what are the lab investigations that can be done in case of diabetic ketoacidosis? The lab investigation relieves hyperglycemia because this is occurring. Diabetic ketoacidosis is occurring because of the uncontrolled diabetes mellitus for a very long period of time. It reveals hyperglycemia, ketosis, and metabolic acidosis with arterial pH 6.8 to 7.3 with increased anion gap. There is fluid deficit that is often 3 to 5 liters, and it can also be greater. Despite of total body potassium deficit, the serum potassium at presentation may be normal. So there is potassium deficit, and the serum potassium level may be normal or mildly high as a result of acidosis. Due to infection, there is leukocytosis, hypertriglyceridemia, and hyperlipoproteinemia that are common. So common things include leukocytosis, hypertriglyceridemia, and hyperlipoproteinemia. The measured level of sodium is reduced. So the sodium level is reduced in the body, and as a consequence of osmotic shift due to hyperglycemia. So due to hyperglycemia, there is shift in the osmotic pressure, and this leads to reduced sodium level. DKA, diabetic ketoacidosis, is characterized by hyperglycemia, ketosis, and metabolic acidosis. So three things are very important: hyperglycemia, ketosis, and metabolic acidosis that we are going to see in case of DKA. Total store of sodium, chlorine, phosphorus, and magnesium are reduced. So the total level of the sodium chloride, phosphorus, magnesium are reduced in the body, and there is increased level of blood urea, nitrogen, and serum creatinine that reflect intravenous volume depletion. Now, how to manage a case of diabetic ketoacidosis? First of all, we have to confirm the diagnosis. The diagnosis is confirmed by plasma glucose level to see the hyperglycemia, positive serum ketone to check for the ketone bodies in the blood, and metabolic acidosis. As we have seen, the three typical features of diabetic ketoacidosis includes hyperglycemia, ketosis, and acidosis, metabolic acidosis. So we have to first of all confirm and manage. First of all, we have to confirm the diagnosis, and then we have to manage accordingly. We have to admit the patient to the hospital in the ICU, and we have to monitor all the vitals. We have to give serum electrolytes because we have seen that there is a depletion of the electrolytes, sodium, chloride, magnesium, all. So we have to give electrolytes to the patient. We have to replace the fluids because the patient was going in hypotension. So we have to give the intravenous fluids. Administer short-acting insulin. First of all, we have to give short-acting insulin because the insulin is deficient in the patient. And access the patients about the cause of precipitating episode. We have to find out the cause that is responsible for development of diabetic ketoacidosis, like whether this is non-compliance, whether the person is not taking insulin properly, or is there any infection, or is there any trauma, is there any infarction or cocaine. Then we have to measure the capillary glucose level every 1 to 2 hours and measure electrolyte levels. So we have to check for the blood glucose level every 1 to 2 hours, and we have to measure for the electrolytes. We have to monitor the blood pressure, the pulse, the respiration, mental status, and fluid intake every 1 to 4 hours. We have to replace the potassium ions. We have to continue above all these things till the patient is stable. And our goal is to maintain the level of glucose 150 to 250 mg per dl, and acidosis is resolved till the time we resolve the metabolic acidosis. Administer immediate or long-acting insulin as soon as the patient is eating. So as soon as the patient starts eating, we have to give the long-acting insulin. So this was all about the diabetic ketoacidosis, one of the important complications of diabetes mellitus. And the next lecture, we will be talking about hypoglycemia. So this was all about this particular lecture. I hope you must have understood the session properly. And in the next lecture, we will be dealing with another important complication of diabetes, that is diabetic hypoglycemia. So this was all for today. We will be meeting with the next lecture, hypoglycemia. So this was all for today. Thank you very much. Have a good day.